presenting a new series, Medically Verbal, where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attempt these processes without the guidance of a licensed medical professional. Case 21. Chief complaint. A 45-year-old male presents with severe, sudden onset of chest pain. History of present illness. The patient reports that the pain started abruptly while he was watching television. The pain is described as sharp and tearing, radiating to his back. He has no history of trauma. He also mentions feeling dizzy and experiencing shortness of breath. His past medical history says that he is hypertensive. He is currently on amlodipine for hypertension. He is a smoker. Occasionally uses alcohol. Father died of heart attack at age of 55. His physical examination reveals his BP as 160 systolic, 90 diastolic, heart rate 110, respiratory rate 22, temperature 98.4 Fahrenheit. His cardiovascular region shows tachycardia, no murmurs, and pulses are unequal between the arms. Tachycardia means when the heart rate is more than 90. His respiratory region is clear to auscultation bilaterally. He has a soft, non-tender abdomen. He doesn't have any edema, but the peripheral pulses are diminished. Initial differential diagnosis: aortic dissection, acute coronary syndrome, pulmonary embolism, pneumothorax, esophageal rupture. Based on this presentation, what do you consider the most likely diagnosis, and what further investigation or management steps would you recommend? What is aortic dissection? It's just as the name sounds. There is a rupture or tear in the inner layer of the aorta. Acute coronary syndrome, when there is diminished or absent flow of blood to the heart. Pulmonary embolism, when a clot is traveling in the pulmonary circulation. Pneumothorax, whenever the air is leaked in the thoracic space. Esophageal rupture, whenever the esophagus has ruptured. The most likely case is aortic dissection. Tearing chest pain is a classic symptom of radiation to the back. It is a very important finding in aortic dissection. Hypertension often leads to aortic dissection. Yes. Unequal pulses between the arm shows that there was some sort of disruption or disturbance of the blood flow due to aortic dissection. What would we do? First of all, we'll immediately perform a CT angiography. Then we'll perform a transesophageal echocardiogram if the CT was inconclusive or if the CT was not available. We'll perform a chest X-ray to see whether the mediastinal is narrow or wide. Additional test would be ECG so that we could rule out myocardial infarction. We'll perform a CBC to check whether there is any sort of anemia because aorta was a large blood vessel. Could lead to blood loss. We'll check for cardiac enzymes to rule out concurrent myocardial infarction. We'll check for D-dimer levels. What are D-dimer levels? It's basically a fragment of protein which is released into the blood whenever there is a clot breakage. If the levels are high, that means there was a clot formed. The clot was broken. So elevated levels can show aortic dissection. It is supportive of it. For management, we'll put them on intravenous beta blockers like labetalol so that heart rate could be reduced and blood pressure could be reduced. We don't want them to have a stroke. We don't want them to develop a shock. We'll put them on intravenous pain management like morphine so that we could reduce their stress and control their pain. Of course, this is a highly invasive case. We'll put them on surgical consultation. Now, there are two types, type A and type B. Type A aortic dissection occurs when the rupture or when the tear happens while the aorta is exiting the heart. Okay, it could happen in the ascending aorta. Type B occurs in the descending aorta. So type A, of course, requires a more immediate management than type B. Corrections or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.